Yeah,
Yes.
okay. All right. So Daniel, if you want to start sharing. So Daniele Travisanuto is from the University of Padova in lovely southern Italy, and the weather is very nice. But he is also a world leader in the use of laryngeal mask airways in newborn infants. And that recently has been advocated as necessary equipment in our resuscitation trolleys by ILCO, AHA, and all the other expert committees. We very rarely have the opportunity to use LMAs, and I think it's a really important procedure to learn. And Daniel has come to us with videos and everything to show us how we can resuscitate preterm infants, as well as giving them surfactant via an LMA. So Danielle, the floor is yours. We will have 10 to 15 minutes at the end for questions and answers. Look forward to your talk. Thank you.
Okay, Julie, thank you for inviting me to this for this presentation. It is early in Italy, but I am happy to be with you. Okay. 1 second. Here we are. Now, just to show where Padua is. I am from University of Padua. Padua is in the north in the northeast of Italy. Is closer to Venice. Venice is more famous than Padua. Padua really is between in the region, in the Veneto region, between Venice and Verona. Is another important city, Romeo and Juliet. But why our university is important? Because Padua is the University of Padua is one of the oldest universities in the world. It was established in 1222. It means that this year we have the 800 years anniversary. So there are a lot of initiatives in our university for this important celebration. If you can, this is the old building, the original building of our university. And if you come to visit Padua, you can find in our university building, original university building, you can see the oldest wood anatomical theater in the world. And you can see also, you can find also the podium of Galileo Galilei. Galileo Galilei spent 18 years of his life in Italy, in Padua in particular. And so we are very proud to have this important person at our university. And if you come to our university building, you can find this monument. The monument is, this monument you can see Elena Lucrezia Cornaro Piscopia. She's the first woman in the world to be awarded at a university degree in 1678. And so just to give you the importance or why we are proud of our university. Okay, now coming back to the topic that Julie asked me to treat with you. We start with the surfactant. We know since a long time that surfactant, given in every modality, natural surfactant, synthetic surfactant, or every kind of strategy as prophylaxis or as treatment, are significantly reduced the incidence of pneumothorax and, more importantly, significantly decrease the incidence of neonatal mortality. And so surfactant is a very strategic or very important drugs that we have in our armamentarium. Now, the question is, okay, we have the surfactant and it is a very practical approach. We have a vial of surfactant, a drug, and we need to spread it in the lung to allow surfactant to arrive to the alveoli. And so the question for administration surfactant is how to spread it to the lung. And the second question is which interfaces we can use. Okay, if we start with the first question, how to spread it, we have three possibilities. We can use a self-inflating bag, we can use a TP's resuscitation, or we can leave the patient in spontaneous breathing. These are the three possibilities. We start from the self-inflating bag, how to spread it with the self-inflating bag. These are all studies, 1994, that show that if you give the surfactant as a bolus instead of slow infusion, we have an improved distribution of the surfactant in the lung. This is the reason why, based on this study, we administer surfactant, or we administered surfactant as a bolus based on the result of these studies. The problem it is animal study. The problem is that these animals were anesthetized and ventilated lamps. And so it was, now we don't use anesthesia in our patient when we give surfactant. The second possibility is to use the T-piece resuscitation to administer, to spread the surfactant to the lungs. This is a randomized control trial published in 2020. The patients were randomized to receive surfactant by using a self-inflating bag or using a T-piece resuscitation. What the authors showed, what the study showed, was that if you use a self-inflating bag, you have a drop, significant drop or difference from before to after the surfactant administration, higher with self-inflating bag compared to with T-piece resuscitation. The difference was 7.58 millimeter of mercury. And so we know how much important is the CO2 to avoid hypo CO2 in our patient. And so this study suggests that probably the T-piece resuscitation, in addition to the PEEP and so on, is probably the best solution. And so the T-piece is better than self-inflating bag when we administer surfactant. The third possibility is the use of spontaneous breathing to leave the patient receiving the surfactant and to spread the surfactant in the lungs by himself or by herself. And the interpretation of this approach is that slower administration in preterm infant with non-invasive respiratory support may improve the surfactant distribution. And so this is the reason why we give surfactant in spontaneous breathing slowly. The second question was which interface we can use. We have three interfaces. We can use an endotracheal tube, we can use a thin catheter, or we can use the laryngeal mask. Okay, we start with the endotracheal tube. This is the very famous study by Dr. Werder, published in New England Journal of Medicine many years ago, that showed that Ensure is compared to the CPAP. We can administer the surfactant by Ensure, intubation, surfactant extubation. And you can see here that there was a significant reduced need for mechanical ventilation, 43% compared to 85%. This is a seminal study in neonatology, and this allowed to introduce the Ensure approach in all our NICU around the world. The second possibility is to use a thin catheter. There are many definitions of the LISA approach. Mr. LISA, I think that in Australia, Dr. Dargaville, and so he used the MIST as acronyms, but really the approach is the same. You use a thin catheter and you put the thin catheter in the trachea and you administer surfactant. This is old, but I like this review that show that LISA is effective in many outcomes, including BPD in all patients, BPD in survivors, death or BPD. And so very important outcomes are positive, are improved if you use LISA compared to other approaches. The only negative aspect of LISA is that you have increased surfactant reflux. This is a survey, a large cohort of neonatology, of patients, of newborns less than 32 weeks in German. And you can see also that this course confirmed the data or the result of the meta-analysis. And so if you use a LISA approach, you can reduce the mortality, BPD, IVH, and retinopathy of prematurity. These are two surveys, one from Europe, that show that 52% of the NICU, of neonatologists in Europe, were using a few years ago, now I think that this percentage is increased, is used LISA or MIST. The percentage of neonatologists that are using LISA in US, as you can see, is significantly lower because the LISA, you know, was born in Europe. I think that in Australia also you have, I think, a high, I don't know in China, but in Australia you have a high percentage of neonatologists who are using LISA or MIST. What are the problems of the endotracheal tube and of the LISA? The problem, or the problem, is that you need to do the laryngoscopy. And when you do the laryngoscopy, we know that some side effects are associated with this procedure. That means when you put your laryngoscope in the mouth of the baby, you can have bradycardia, hypoxia, important hemodynamic changes that may be associated with IVH, and of course is a painful procedure. This is the study from Gopper. The first study is published in Lancet 2011, and they use a soft catheter for the LISA approach. And I counted the time of the laryngoscope was positioned in the mouth of this baby, and it was almost 1 minute. And so the laryngoscope in this video that is associated, is attached to the paper, the laryngoscope lasts 1 minute, about 1 minute in the mouth of the baby. And we know that LISA is associated also with bradycardia and desaturation. This is a study that we have, it is a thesis of a medical student. We have submitted these results. In this randomized control trial, we evaluated the time of intubation with a soft catheter or compared to a rigid catheter. Because we have two catheters. And what we found was that time of device positioning was significantly shorter, 19 seconds compared to 40 seconds with the rigid catheter compared to the soft catheter. And with the rigid catheter, the procedure, the first attempt was significantly higher compared to the soft catheter. And so the second problem is that if you do LISA or if you do the INSURE, you need a skill of the procedure. So you need skilled neonatologists. What is the learning curve for intubation? These are two studies published in anesthesiology journal, and these authors were interested in to know which was the learning curve for intubation, and they defined the appropriate level of proficiency as acceptable failure rate at the first attempt of 10%. It means that the participant had to put the endotracheal tube in the trachea 9 times out of 10 attempts. This study was conducted in an ideal situation, operating room, adult patient, sedated and anesthetized patient. And what this author showed, this study showed, was that you need more or less 50 attempts, the exposure to 50 attempts to achieve an acceptable failure rate at this attempt. And so to achieve the appropriate level of proficiency in an ideal patient, adult patient, anesthetized patient, you need to have an exposure to 50 attempts of intubation. We don't know really which is the learning curve for neonatologists, because neonatologists are working in a different situation. Many times we have a small patient, high-risk situation, delivery room, and so on. And so, of course, the learning curve is surely longer for anesthesiologists. This could be a problem because the success rate at the first attempt, for example, from this study from Elizabeth Foglia, showed that the success at the first attempt including pediatric resident, neonatology fellow, attending neonatologists, is only 46%. And the problem is that the exposure of our pediatric resident to intubation is really very short. This is a study from Tina Leone that showed that at the University of San Diego in 1994, a pediatric resident had the possibility to try 38 intubation, and 24 of them were successful. But just a few years later, it means 20 years ago, one pediatric resident had exposure to 12 intubation attempts, and only 4 of them were effective. The malposition on the tracheal tube is very frequent. This is what happened in our region, and as you can see here, that very frequently, from 20% to 33% of our patients have a malpositioning of the endotracheal tube conducted or performed in the peripheral hospital or rural hospital. The problem is if you put the endotracheal tube in this position, in the main right bronchus, and you give surfactant, you can have problem. And so the final message of this few slides is that intubation is a complicated skill to learn, is not a children play. And so what we know is that the actual modality or interfaces, that means endotracheal tube on T-catheter, have a high invasivity and a high skill of neonatology, of health caregivers is needed. And so in this case, we can think to the third possibility, the third interface. In this slide, you can see Dr. Archie Brain, who is the inventor of the laryngeal mask. And you can see here 2 photographs from an experiment that was conducted by Dr. Archie Brain at the London Hospital in 1983. The experiment consisted in positioning the laryngeal mask in himself for 3 times, and this experiment was conducted in front of the London Hospital Ethics Committee, and here you can see the reaction. Dr. Archie Brain conducted this study to convince, this experiment to convince the Ethics Committee of the hospital to give the permission, the approval for the first study in August. This is the first study published on the laryngeal mask by Archie Brain in 1983, and I would like to show you that the title, the laryngeal mask, is a new concept in our airway management. It is not a new device, but is a less invasive approach. Since that time, there was an important evolution of the laryngeal mask concept, many devices, many prototypes that improved the use of the laryngeal mask among the users. What are the advantages of the laryngeal mask compared to the tracheal tube? There are really 2 very important advantages. The first is easy of placement. If you take 100 patients in the room and you ask to put the laryngeal mask in the mannequin, 99% of them will do the procedure effectively. And the second very important advantage of the laryngeal mask compared to the tracheal tube is the reduced invasiveness. Because the laryngeal mask stays here in the supraglottic area, the tip of the laryngeal mask goes to the esophagus, not to the trachea. And while the tube, here we have the vocal cords, and the tube give or damage the vocal cords. And so easy placement and reduced invasiveness. If these are important advantages for the adult patient, you can imagine that this advantage is more important for newborns, in particular for small newborns. Here I prepared, because based on your request, 2 videos where you can see the use of the laryngeal mask. senza nemmeno che lo chiamo. There are laryngeal masks that are uncuffed. This is an uncuffed laryngeal mask. You end the laryngeal mask in this way. You take the secretions, you push again the palate, and you arrive in the esophagus. And after you can start ventilation. The time needed for positioning of the laryngeal mask is 4 seconds. And so it's a very, very fast time for the positioning. And then you remove the laryngeal mask in this way. Now you can see the procedure in the real time. You take this is the eye gel, uncuffed laryngeal mask. You take the secretion, you go against the palate, and you start ventilation. In the market, there are also cuffed laryngeal masks that are different from the uncuffed. The cuffed laryngeal mask have a cuff at the end. And so what you have to do is to put the air in the cuff. You inflate the cuff to check that it is appropriately prepared. It is not damaged, no leak in the mask. In the cuff, you have to deflate the cuff. The insertion has to be made without air. And so the mask has to be deflated. And after, the procedure is the same. You take the secretions and you push against the palate and you arrive in the laryngeal inlet. At this point, you have to inflate the cuff with 4 milliliters of air. And after you are ready for you check the air in the pilot balloon, yes, and after you start ventilation. With this kind of laryngeal mask, you can have also the gastric access, if it is available, and you can put your gastric tube in the stomach. This could be important to take out the air from the stomach or take out or to remove the gastric liquid, for example. You can leave it the gastric catheter, and you can go with the ventilation. You can take out the air from the stomach. And after, you can remove the laryngeal mask. Here, the cuff has to be inflated again. And you can see here the catheter, the gastric catheter that was in the tip of the laryngeal mask. That means that it went in the right place, and so in the stomach. Okay. What are the advantages of the laryngeal mask in the newborn? This review, Cochrane review, published in 2018, showed that if you start with in late preterm and full term newborn, you start with the laryngeal mask. In patients who need who need the positive pressure ventilation, you start with the laryngeal mask, or you start with bag mask ventilation, you significantly decrease almost 75% the need for intubation. If you start with the laryngeal mask, compared to bag mask ventilation, you reduce the time of ventilation. And so in a summary, what this Cochrane review show is that in late preterm and full-term newborns who need positive pressure ventilation, if you start with a face mask, you achieve effective positive ventilation in 84% of the patient. But if you start with the LMA, you achieve 97% of the effective positive ventilation. Also, this very recent review from the ILCOR group, the first name is Jamada, showed that endotracheal intubation is significantly decreased when you start with the laryngeal mask compared to face mask. And the conclusion of this study are that among late preterm and infants who require resuscitation at birth, ventilation may be more effective if delivered by a supraglottic airway rather than face mask, and may reduce the need for endotracheal intubation. And so also the ILCOR guidelines or ILCOR recommendation are in favor of the laryngeal mask. You know that the algorithm, American Heart Association algorithm introduced the laryngeal mask in 2015, and it was confirmed in 2020. The European guideline recommend the laryngeal mask also in the algorithm for 2 times in the last version of the laryngeal mask. But the question is the laryngeal mask available in our delivery world? I don't know in your world, we can discuss later. This is a recent review, is better survey that included 446 European hospitals, and what we found was that half of the hospital, 56% of the hospital in Europe have the laryngeal mask in their delivery ward, but 44% don't have it. The second question regarding the laryngeal mask in this survey was, if you face a neonate in need of PPV, you start ventilation with only 1% would like to start, of the directors of this hospital, suggested or stated that they started ventilation by using the laryngeal mask. And so the laryngeal mask really is not very frequently used. In these 2 review studies, we identified 5 potential applications of the laryngeal mask. Congenital airway, we can use the laryngeal mask during neonatal anesthesia. For example, we use during the treatment of the retinopathy of the prematurity, during neonatal transport, during neonatal resuscitation, and during surfactant administration. Now we go to the use of laryngeal mask during surfactant administration. When we had this idea, our first idea was to use a long catheter, to go with the catheter beyond the tip of the laryngeal mask, and to arrive in the, to go beyond the vocal cord and to spread the surfactant in this way. This was the first idea that we had. And so we treated the first 4 patients, but the results were that the oxygenation decreased instead to increase. And so we were very depressed after this 4 treatment, but we tried to understand the problem, because maybe that if you put your catheter beyond the tip of the laryngeal mask, you don't know where your the tip of your catheter goes. It may be the tip of the catheter goes to the esophagus inside of the trachea. And so these are studies in labs that we conducted, and as you can see here, you can damage when the upper airway, when you put your catheter for surfactant administration in a blind way. And so we decided to change completely our strategy. We decided to put the catheter not here, but at this point proximally. And so to spread the surfactant from here, and so we used at that time, we used a self-inflating bag to spread the surfactant by using a self-inflating bag. And we published the first 8 patients, and gestational age was average, medium gestational age was 31 weeks. The birth weight was ranged between 800 grams to 2.5 kilograms. These patients were receiving nasal CPAP at 5 centimeter water. The FiO2 was 0.5, the average, and this was the range between 0.4, 0.8. And the postnatal age of these 4 patients was 28 hours. With this new approach, we found that the oxygenation significantly improved in all the 10 treatments, and so this is the mean after 3 hours. And this was with the new technique. It was the oxygenation with the first technique when the catheter tip was positioned behind the LMAT. And if you want to see the results in terms of FiO2, we have a significant decrease from 55% of oxygen to 31% of oxygen. Here you can see 2 chest X-ray of 1 patient. Before the surfactant administration, you can see the bronchogram and the microgranulia, and here you can see 2 hours after surfactant administration by LMA that the volume and transparency is significantly improved. Here is a load photo where we were young and we were treating a patient in our niche. The first observational study showed that the laryngeal mask, the feasibility and efficacy of the laryngeal mask was positive, apart from this group of patients, because the patient with the catheter was, when the catheter was positioned distally, and we did not find any complication. In this review study, we put together, we conducted a review meta-analysis on the available study on the use of the laryngeal mask for surfactant administration. We identified 5 studies. 2 studies compared the laryngeal mask with the nasal CPAP, and 3 studies compared the laryngeal mask with Insure technique. In this study, 3 different models of the laryngeal mask were used, and the results included are that if you use the nasal CPAP plus surfactant via laryngeal mask, compared to the nasal CPAP, you significantly decrease the need for intubation and mechanical ventilation in your patient. And so the laryngeal mask works. This is the study that, the Verde study that I have already shown you, that showed that you have a decrease of need for mechanical ventilation when you use Insure, and so you use the tube surfactant administration compared to leave the patient in nasal CPAP. This is our studies, the review, and here is the Verde study. As you can see here, there is a very similar decrease of the need for intubation, mechanical ventilation when you use the laryngeal mask or when you use the Insure approach. If you use the laryngeal mask for surfactant administration compared to nasal CPAP, you can decrease the oxygen supplementation, the FiO2, at 1-6 hours after surfactant treatment. If you use the nasal CPAP, the laryngeal mask for surfactant administration, or use endotracheal intubation, it means Insure, you have the same effect. No differences in terms of oxygen supplementation at 1-6 hours after surfactant administration. And so this review showed that laryngeal mask administered via laryngeal mask is effective, has the same effect as when we use the Insure approach. The conclusion of this study were that surfactant administration via supraglottic airway device reduced the need for intubation, mechanical ventilation, and increased the amount of required surfactant because there was an increased need of surfactant. Short-term oxygen requirement decrease with supraglottic airway devices compared to nasal CPAP alone, but are similar to Ensure approach. Available literature include few small, poor quality studies that prevent to draw strong conclusions. Now we cannot say we are sure with the laryngeal mask. And the conclusion of that review was that surfactant administration via SAD should be limited to clinical trials. And so LMA and surfactant administration. What we know in this moment, we know that if you put the catheter beyond in a blind way, and you try to go beyond the tip of the laryngeal mask, it could be dangerous. And so I think that is, you have not to do it. If you use the catheter that is behind the laryngeal mask tip, it is possible, but in this moment, it's not, in my opinion, it is reasonable, but it's not the idea. The idea is the future, and now I want to show you some data, is that to use the video laryngo, video LMA for surfactant administration. And so in this way, you can see where the tip or where your catheter goes. If the catheter goes here, this is the, in my opinion, the dream. So that is not a dream, is a real approach. This is the animal studies that we conducted in pig. We put a video camera here. Here you can see the catheter, and we treated the pigs. We use puractant alpha mixed with technetium. And so you look at the surfactant deposition by gamma scintigraphy as percentage of administered dose. And so we treated 3 groups of animals. The control group was the Ensure approach. We intubated the animals and we gave surfactant. Here you can see that distribution of the surfactant in the lung is good, is perfect. When you use the LMA that is behind the tip of the LMA is behind the tip of the laryngeal mask, you can see that a part of the surfactant goes to the lungs, okay? But as you can see here, also a part of surfactant went to the stomach. Here is the stomach. And so you have a loss of surfactant. If you use a video laryngeal mask and you try to put the laryngeal mask, you can see that the most part of the surfactant went to the lungs. A little part of the surfactant remained in the upper airway, in the larynx, while not surfactant went to the stomach. And so if this part, if you use the video laryngeal mask for surfactant administration, could be the most reasonable approach. What are the future directions? Now we have several brands of the neonatal laryngeal mask. The most part of them are cuffed laryngeal mask, while iGel is uncuffed. This is a study from an Australian group, from Tracy. They show that the leak of the laryngeal around the mask was significantly lower when you use the iGel, and so it was only 6% compared to the Supreme that was 50%, about 50%. And so the laryngeal mask in this mannequin study was more effective in terms of leak, but this study was conducted in a pediatric mannequin, no neonatal mannequin, and so and in addition, it was a mannequin study, was not a patient study, and so we have to recognize the limitation of this study. This is another laryngeal mask. The name is Supreme laryngeal mask. It's an inflatable laryngeal mask, a cuffed laryngeal mask. The advantage of this mask is that you have a gastric access, and so you can use this, for example, the gastric access to be sure that the laryngeal mask, the tip of the laryngeal mask is in the right position, and so in the esophagus, upper part of the esophagus. Laryngeal mask, the size 1 is recommended for patient with a birth weight between 2 and 5 kilograms. And we know that we need to treat patients with a smaller size. There is only one laryngeal mask in the market in this moment that is a size 0. I received it 2 months ago. I never use it, and so I have not experience, but it's available in the market. The only complication that has been reported in the use of the laryngeal mask is from our group. We treated this patient not with a surfactant for resuscitation in the living room. It was a very small patient, 700 grams. We use a size 1, a pediatric resident. Our pediatric resident used it, and you can see here a lesion of the upper esophagus that luckily or fortunately completely recovered 1 week later. And so this is the only complication in the use of the laryngeal mask reported in newborns. What is the evolution of the supraglottic airway device? This is the first generation. This is the second generation where the gastric access was included. And this is the third generation. There are now 2 companies that have put in the market the video laryngeal mask, but is only for, of course, adult patients in this moment. Previous study have measured the measures, have evaluated and assessed the measure of the trachea. And based on this study, we use the endotracheal tubes. But we have a lack of information of the anatomy of the upper airways in the newborns. And so in this study, the aims were to collect anatomical measure of the upper airways in cadavers or fetus. And we were interested in assess the relationship between anatomical areas and the size of size 1 LMA. This is the case report form. This is the laryngeal mask, models of laryngeal mask that we use. I would like to show you that the laryngeal mask here is in the esophagus, in the upper part of the esophagus. This is the trachea, okay? And these are some mold. And this is another short video, just to show you how the laryngeal mask is working. Now we ventilate it. And you can see here that you can ventilate very efficiently the lung. And you can see here the laryngeal mask that is in the inlet in the laryngeal inlet. We evaluated 16 fetus, and now we have the measures. What we know is that if you have a patient with a body weight of 400 grams, the size 1 supreme LMA is clearly too much big for him. The conclusion of the study is that the study reports for the first time the anatomical size of the upper airways in cadavers of fetus. This data add information for design is suitable and safe laryngo-supraglottic airway device for preterm infant. Available laryngeal mask using neonate weighing more than 2 kilograms are potentially dangerous in smaller patients. These are the surf laryngeal masks that we are developing, and we are at good point now with a company, Italian company. We hope to be able to prepare our prototype ready in a short time. What are the gap of knowledge when we have a laryngeal mask and surfactant? We don't know which model is better to use, inflatable or not inflatable cuff. We need to understand which is the best size, the procedure for position. Do we need to sedate the patient, or we leave the patient? We prefer to leave the patient with spontaneous breathing. Is better to use a slow or bolus administration. Is important to sedate the patient? I don't think it is necessary. Probably we could consider local anesthesia, and of course the training is another important aspect. And so coming back to my conclusion, arriving to my conclusion, how to spread it. I think that spontaneous breathing probably is the most appropriate approach based on the knowledge that we have now. The TP resuscitation is reasonable. but the self-inflating bag is better to avoid due to, for example, the how can we have affect the CO2 changes. Which interfaces? Endotracheal tube probably is not a good approach. Thin catheters seem to be, in this moment, a good approach based on the meta-analysis that I show, but also there is a recent meta-analysis that confirm. The laryngeal mask, I put a smile, happy, a smile that is thinking about other possibilities in this moment. Okay, I have concluded my presentation, but now if you give me the time, I would like to show you this video. Is a video of more or less 3 minutes. And where you can see here how to give the surfactant to your patient. May you see the video?
No, it hasn't come on yet.
You might have to stop sharing the PowerPoint.
Okay, yes, I have to stop. Yes, you are right. One second, I arrive. Condividi schermo.
That's okay.
I start. May you see the video now? Okay.
Yes, got it.
This is a video from Dr. Carrie Roberts. Oh. No, sorry. No, it was not the video that I would like to show you. One second. Come back to my presentation. Take this one. No. Okay. No, I don't want to show you this video. Sorry. One second, I arrive. Are you there?
Yeah, all good. We always it always comes under pressure, right?
Sorry.
That's okay.
Okay, 2 minutes video. Okay, this is a video from Dr. Carrie Roberts from University of Minnesota. We are working together, and you can see here she's using a gel laryngeal mask. Here you can see the end-tidal CO2 detector. They use a connector, a special connector to connect the surfactant, the syringe with surfactant, and now they are spreading the surfactant to the lung. As you can see, I have the catheter stay before the tip of the catheter of the laryngeal mask. It is the third aliquots. Now the laryngeal mask is removed and the patient is left with the nasal CPAP approach. Now they are going to see if the surfactant went in the stomach, to be sure that most of the surfactant went in the lungs. And in this case, there is not surfactant in the, okay. Okay, I think that is all.
Okay, thank you, Danielle. I've got lots of questions, but I think one of our participants, Shiv Hebandi from Queensland, has raised his hand. May I ask you to unmute Shiv and maybe show yourself if you want to ask the question directly? Please type your questions on the chat pane if you're a bit more shy.
Oh, sorry, Julie, I think it was a mistake.
Okay, no problems. No problem, Shiv. Danielle, where did you get the cadaver mannequin from? Oh my goodness. That was an amazing model. So may I ask Peter Dargaville, he's online, to comment on it, Peter?
Hello, Julie. Hello, Daniele.
Hello.
Hello, Peter.
How are you going? I'm sorry, this is not a great time for me to be joining just because I'm on my way to a tennis game. But
You're always playing tennis on Thursdays. Yeah. Okay. Sorry,
right.
Forgot that.
But I enjoyed the presentation, and my thinking about LMA, I think, is probably known to you, Daniele, that the issues are, first of all, we definitely need evidence comparing head-to-head the use of LMA with thin catheter for surfactant delivery, and we'll hopefully have that in a while with the Surfactante study that Callum Roberts is running as the CI here in Australia. And that will very much help to decide whether there's an advantage of one over the other. And the second things as questions to you are, is it easy to deliver surfactant with an LMA with the baby spontaneously breathing? Because most of the videos show PPV being used. And secondly, what do you recommend for the baby less than 1,200 grams where the current LMAs are not recommended?
Okay, thanks, Peter, for this question. Yes, our American colleagues are very enthusiastic for surfactant administration in a spontaneous breathing patient. I think that it can work, but I think that okay, the background is the laryngeal mask was created for anesthesia, and so the patient has to be happy to receive the laryngeal mask. This is important starting point, in my opinion. And when I treat many patients with this approach, and you have some patients that are very happy. You put the laryngeal mask when the laryngeal mask is in the right place, in the laryngeal inlet. You start ventilation. They are very happy to breathe with the laryngeal mask. And my idea is that probably the ideal approach in spontaneous breathing is to use a local anesthesia. It means, for example, giving sucrose with a little bit of lidocaine, 2% of lidocaine to convince the patient that laryngeal mask is good for during the spontaneous breathing. This is my point of view. I have not, of course, data to show it, but I think it's a good approach. The second question, now we have not a smaller size of the laryngeal mask. I told you that a new company, the RQ, I put in the market, is not, we can say because it's in the market, a smaller size, the size 0 of the laryngeal mask. The company write in the sheet that the laryngeal mask, that model is can be used in patients less than 2 kilograms, but there is not a range, just less than 2 kilograms. I don't know how much low you can go, down you can go, and so these are my answers.
Julie?
Hi, Rodney. Okay, Daniel, this is Rodney from Liverpool, one of the units in Sydney.
So,
Hi.
Julie, Hello, thanks for the talk, Danielle. I've read a lot of your articles about LMA. We've got experience at Liverpool with LMA, surfactant, which we've been using since 2019. So we've given about 60 cases in our unit, and even at the private hospital next door, which is a unit that doesn't have on-site registrars, we've given about 10. So I'll tell you our experience is, we've been using mist since 2016, but we found the bigger babies sometimes a bit vigorous with mist, and it's harder to do. And we tried some sedations like morphine, 50 marks per kilo, but it wasn't working. So we looked at all the studies on LMA surfactant, and it seemed to work well. A lot of the studies were quoted by Daniel in his talk. And so we started in 2019. There's a learning curve with it, and I think we're now quite good. And the CMO has just walked out the room here. like he's given probably the most, and he gave the first couple, and I think it's good if you can have success with the first couple, because then the unit gets on board. I reckon if you have the first couple that are not good, maybe they'll chuck it out. But luckily our first couple were good, and we've had good success with it. And we've videoed quite a lot of us, and we've like learned more and more by the videos. And now 3 years later, I think we've got it, like perfected it. So we can thank our CMOs for pushing it through, and also for getting the first couple that were good, that people were saying, yeah, let's give LMA surfactant, because they had seen good ones to start with. So I think it's important to have it, like, maybe get taught how to do it, so that when you first give it, you don't get discouraged.
No,
that's great. Mm-hmm.
Yeah, no, but I agree. For example, in the largest patient, you can use, for example, when we give Lisa, we use Lisa. For example, you give propofol, and with propofol, you can do the procedure in a very easy way, because the patient is sedated, and for example, for laryngeal mask could be another good opportunity, and because the damage due to the ventilation is not so important. If you think, for example, there is a lot of interest in the use of sulfate administration in low resource setting, where you have not the opportunity to give to intubate and to give positive passive ventilation, but you have just a CPAP approach. But as my approach is to be very, have caution, because I am afraid to give enthusiasm to the people. And for example, I found in the hospital in our area, they use the gastric tube. They put the gastric tube in the esophagus. There was a perforation of the esophagus. Just to give an example of, if you give a message, people are very enthusiastic, and after maybe that they do several problems to the patient. My idea, however, remains that also is the training nodule patient. As neonatologists, we arrive after the anesthesiologists in general, because they have more exposure. And the future for the laryngeal mask is the video laryngeal mask. If you have a video laryngeal mask, is very easy to understand where your catheter goes and how to manage the patient. The other aspect is, the other problem is, okay, I agree with you, is how to manage the sedation, the acceptability of the patient of the laryngeal mask, because the patient has to, but with preterm newborns, in general, we could do it, in my opinion, with, for example, I repeat, local anesthesia, because, and so that is my opinion. So some patient, it was very enthusiastic. Also, our staff, that was very effective. Some patient we found, we as you did, as was your experience, we needed to give Surfactante in for example, with a insure approach, because the procedure failed. And so I agree.
Thank you, Rodney. Maybe we give Liverpool a yell to give us some training, because you're a bit closer than Danielle to us. Is that okay?
Yeah, anytime. Yeah.
The training,
So
if you want another opinion on the training, I think that in operating room or for resuscitation, I want to use for the resuscitation approach, the training really is very, very faster. We went in Uganda with, we organized one afternoon training, 2 hours, 3 hours training on laryngeal mask with the midwife in Uganda. And I can see you that they never seen the laryngeal mask. And after we went in the delivery room for the feasibility study was that we were enthusiastic, very effective. And we published the second study after the mannequin study. And after we organized the big randomized control trial, and out of 600 positioning of the laryngeal mask, no problem. Only 2 patients have a small amount of blood in the mouth compared to the face mask. And so it's safe and it's easy to teach. From this part, we went in the living room with a severely asphyxiated newborn, and you see that chest movements were better than the mannequin in the hands of a midwife who without experience in neonatal resuscitation. And so in that part, I am enthusiastic in that use. For the Surfactante administration, we need some improvements in this moment.
some more evidence, I guess. Yeah. If you, what is your normal? Sorry, sorry, Rodney, go for it.
With giving LMA surfactants, it's also quite easy, but you do learn things like it must be a 2-person procedure, better to give it with spontaneous breathing, give it slowly. You know, that kind of thing you learn, like not in the first one, but by the time you've done your 50th one, you kind of realize all those things. But
so your first choice is LMA surfactant now, both of you, Danielle and Rodney?
Well, we only usually more than 2 kilo babies still.
2 big babies. So if you had a turn like a 36 weeker or something.
He'll teach you. He'll teach you.
And which and which model are you using? The iGel or a Caffe laryngeal mask?
iGel.
iGel.
Okay. iGel. And the one that they're going to use in the study from the Melbourne guys is also the iGel.
Yes, I know it, yes.
So Danielle, in your unit, if you have a baby who's about like 1 kilo plus, who you think would be okay with an in and out surfactant, your first choice would be LMA, is it?
No, in 1 kilo, our first choice is Lisa approach.
Okay. How big will they be when you do LMA as the first choice?
When they are more than 2 kilograms, we consider to use the laryngeal mask. Yes.
Okay, but when you do resuscitation, it will be LMA first.
Not first, but sometimes yes. It depends on the attending doctor that is in the delivery room. I invite to use the laryngeal mask for training purposes, because I would like that our pediatric resident have in their mind that the laryngeal mask may be used. And for example, last 2 weeks ago, I was in a peripheral hospital. A baby needed positive pressure ventilation. the colleagues failed face mask ventilation, I told him, please use the laryngeal mask. And in 1 second, the patient recovered. But this was,
Right.
all the staff was really surprised of the effectiveness of the laryngeal mask, because it's when we need to do a mental change, as the anesthesiologist did when the laryngeal mask was in the market the first time.
Right. Okay. You have one question from Suresh, who asks if delivering atomized surfactant via LMA is better than administering with the catheter via LMA. Ooh.
No, this is of course a great question. Thanks, thanks, Suresh. You know that in this year, a paper from an Italian group, Dr. Dani is the first name, was published in the Journal Pediatrics, where they give surfactant, nebulized surfactant by nasal CPAP, not by laryngeal mask, and it was not effective. And so I decided not to introduce the nebulized surfactant administration in my presentation due to the time. But nebulized surfactant administration now is not an effective approach. And I think that the most powerful surfactant remain not in the main tube of the laryngeal mask. And so maybe that is the future, is reasonable, but is not possible now due to the machine for surfactant for the nebulization. You have also a great experience in Australia for the nebulization surfactant.
Okay. We are unfortunately out of time. You had more than 170, almost 180 people online. That was amazing talk, Danielle. Thank you so much, especially after having no sleep last night. So
don't worry.
Really appreciate it. And with your permission, we'll go through and see whether there's anything weird about the video. But if it's okay, we would like to post it online in our WhatsApp group, if that's all right.
Yes, of course.
And we might all come to Padova and learn how to do it, or maybe even Liverpool.
Okay.
All right. Thank you so much, and hope you get some rest.
Thank you for your invitation. Ciao. Bye, Raul.
Ciao.
Thank you.
Bye.
Bye.